Welcome back to the Therapeutics Chronicles. I'm your host, Momin Wali, and today we're taking a deep practical look at one of the most frequently prescribed antibiotics in all of medicine, Amoxicillin. It's one of those medications everyone thinks they know well, yet most real-world errors in infectious disease prescribing involve this drug. Underdosing, wrong frequency, incorrect durations, misinterpreted rashes, and unnecessary switching to broader agents happen every single day in community and primary care. Whether you're managing strep throat, pediatric pneumonia, otitis media, dental infections, or part of an H. pylori regimen, understanding how to use amoxicillin properly is essential. And because it's so common, even small mistakes can ripple into big consequences for patient outcomes and resistance patterns. So in this episode, we're going to break down the mechanism, the clinical role, dosing strategies, safety considerations, drug interactions, and several real-world cases. And later, I'll walk you through a dream counseling simulation for amoxicillin. Let's start with the fundamentals. Amoxicillin is a beta-lactam antibiotic, part of the aminopenicillin class. It works by binding to penicillin-binding proteins and inhibiting bacterial cell wall synthesis. Without a functioning cell wall, bacteria soften, swell, and eventually rupture. Pharmacodynamically, amoxicillin is time-dependent. That means how long the drug concentration stays above the minimum inhibitory concentration determines how effective it is, not how high the peak gets. This is the reason dosing frequency matters so much and why 3 times daily used to be standard. With modern formulations and evidence, twice daily dosing is effective for most conditions as long as the total daily dose is adequate. In terms of spectrum, amoxicillin covers many Streptococcus species very well, including Streptococcus pneumonia, and it is one of the few oral agents that reliably covers Enterococcus faecalis. It has activity against non-beta-lactamase producing Haemophilus influenzae. It does not cover atypicals, it does not reliably cover Staphylococcus aureus, and it has no activity against MRSA. It is also not the right choice for most gram-negative infections. Despite its limitations, amoxicillin remains first line for many infections because it strikes a rare balance between narrow spectrum, high effectiveness, and excellent safety. It avoids disrupting the microbiome the way broad-spectrum agents do, and it works extremely well when used appropriately. Now let's get into the dosing, because this is where the majority of real-world mistakes happen. For strep pharyngitis, adults are typically treated with 500 milligrams twice daily for 10 days. Children can receive 50 milligrams per kilogram once daily or 25 milligrams per kilogram twice daily. The full 10-day course still matters for eradication and preventing complications like rheumatic fever. For pediatric otitis media, Canadian guidelines emphasize high-dose therapy. That's 80 to 90 milligrams per kilogram per day divided twice daily. This higher dose is required to overcome penicillin non-susceptible Streptococcus pneumonia. Underdosing in otitis media is one of the most common pediatric prescribing errors, especially when lower concentration suspensions are mistakenly used. For pediatric community-acquired pneumonia, doses range from 75 to 100 milligrams per kilogram per day, depending on local guideline variations. For dental infections, the adult dose is usually 500 milligrams 3 times daily for 5 to 7 days. Assuming proper drainage is achieved and in H. pylori therapy, amoxicillin is typically 1 gram twice daily as part of triple or quadruple regimens. In renal impairment, you should extend the dosing interval when creatinine clearance is under 30 milliliters per minute. Avoid the 875 milligram tablets in severe renal impairment and give doses after dialysis in hemodialysis patients. Let me give you one of the classic examples of pediatric dosing errors. A 4-year-old weighing 16 kilograms is prescribed 5 milliliters of a 250 milligram per 5 milliliter suspension twice daily for otitis media. That sounds typical, but the total daily dose is only about 31 milligrams per kilogram, far below guideline recommendations. The correct dose should be closer to 80 milligrams per kilogram per day, which works out to roughly 8 milliliters of the 400 milligram per 5 milliliter suspension twice daily. These errors are incredibly common, and they make a huge difference in treatment success. Now, let's talk about adverse effects and safety. Amoxicillin is generally well tolerated. The most common side effects include nausea, mild abdominal discomfort, loose stools, and occasionally a benign rash. One of the most misunderstood aspects of amoxicillin is rash evaluation. Many children develop a non-itchy maculopapular rash during viral infections, especially when they're taking amoxicillin. This is not an allergy, but it often becomes documented as penicillin allergy, which later leads to suboptimal therapies like azithromycin or clindamycin for infections that should have been treated with amoxicillin. True allergy involves hives, swelling, wheezing, or anaphylaxis. Serious reactions are rare but important to know. These include C. difficile infection, Stevens-Johnson syndrome, serum sickness-like reactions, and hemolytic anemia. The key contraindication is a true immediate hypersensitivity to beta-lactams. Let me give you a real example. A child develops a widespread red rash while taking amoxicillin for what was actually a viral infection. It was never itchy, never urticarial, and never accompanied by swelling or breathing issues. Still, the provider documented it as penicillin allergy. Years later, that label leads to inadequate therapy for otitis media and repeated treatment failures. After reassessment, the rash was clearly viral, not allergic. Avoiding unnecessary allergy labeling is a major stewardship issue. Now, let's move to drug interactions. Amoxicillin may increase the effect of warfarin by altering gut flora or interfering with vitamin K metabolism. When combined with allopurinol, the risk of rash increases. When combined with methotrexate, especially at higher doses, the risk of methotrexate toxicity increases due to competition for renal elimination. And even though the evidence linking amoxicillin to decreased oral contraceptive effectiveness is weak, many clinicians still discuss backup contraception for high-risk scenarios. Combination therapy is worth mentioning as well. Amoxicillin alone is often the correct choice for strep, pharyngitis, pediatric respiratory infections, and dental infections. But when beta-lactamase producing organisms are suspected, especially in recurrent sinusitis or in infections involving certain gram-negative species, amoxicillin clavulanate is more appropriate. Let's connect that with a real case. A patient taking warfarin begins amoxicillin for a dental infection. 3 days later, their INR jumps from 2.4 to 4.2 holding warfarin briefly, rechecking INR in 48 to 72 hours, and educating the patient about bleeding risks are essential steps in preventing complications. Now I want to walk you through 4 real-world scenarios that highlight common amoxicillin issues. The first is a dosing mistake. A 32-year-old patient with strep throat receives 250 milligrams 3 times daily. This is underdosed and the patient returns 5 days later feeling worse. The correct adult dose is 500 milligrams twice daily for 10 days. The second case is a drug interaction oversight. A patient on methotrexate for rheumatoid arthritis receives amoxicillin for a urinary tract infection. 3 days later, they develop mouth ulcers, fatigue, and pancytopenia. The interaction is a competition for renal clearance and it was missed. Acute methotrexate toxicity is in action and the symptoms are clear. The third scenario is an adherence challenge. A child prescribed high-dose amoxicillin is given the medication using a teaspoon instead of an oral syringe. The dose ends up being almost half of what it should be. Once the caregiver receives proper counseling and a demonstration using a syringe, treatment success improves dramatically. Now we're ready for the DREAM counseling portion. Before we begin the simulation, let me explain exactly what DREAM stands for, because this framework is extremely helpful in OSCE, in real-world counseling, and in quick patient interactions. DREAM is the quick checklist we use to make sure every patient walks away fully understanding their medication. D stands for direction, how to take it, how often, and for how long. R is the reason, why they're taking this medication in the first place. E is the expected onset, when they should start noticing improvement and what to realistically expect. A is for adverse effects, the common ones, the rare but serious ones, and what to watch out for. And M is monitoring, what the patient should keep an eye on, and when they need to reach back out for reassessment. Let's use DREAM to counsel a parent picking up amoxicillin for a child with otitis media. Here's what that might sound like. So, for your child, you'll give 8 milliliters of amoxicillin twice a day, roughly 12 hours apart, and you can give it with food if their stomach is sensitive. If you miss a dose, just give it when you remember, unless it's almost time for the next one. We're using this because their symptoms fit a bacterial ear infection, and amoxicillin is the safest and most effective first option. You should start seeing improvement over the next 2 to 3 days. Less fever, less ear pain, better mood. Mild diarrhea or stomach upset can happen. But if you see a rash, trouble breathing, or they're getting worse, stop it and get care right away. Keep an eye on their fever, pain, sleep, and overall activity, and let your provider know if there's no improvement after 72 hours. That is the dream method in action: simple, structured, and complete. Let's reinforce what we've learned with a few quick rapid-fire questions. Does amoxicillin cover atypical organisms like mycoplasma? No, it does not. What is the primary contraindication to using amoxicillin? A true beta-lactam allergy. Can amoxicillin cause hypoglycemia? Not on its own. And what is the Canadian high-dose regimen for pediatric otitis media? It's 80 to 90 milligrams per kilogram per day, divided twice daily. To close, amoxicillin remains one of the safest and most effective antibiotics in our toolkit. When used properly, it achieves excellent outcomes with minimal collateral damage. When misused, even small errors can lead to treatment failures, unnecessary allergy labels, or avoidable complications. Use the right dose, the right duration, and the right counseling, and you will dramatically improve patient outcomes. If this episode helped you, make sure to subscribe and share it with your colleagues. Join our WhatsApp and Telegram groups for clinical cases, questions, and discussions. The links are in the description. Connect with me on LinkedIn for more clinical content. And as always, catch mistakes before they catch you.